Great, thank you so much, Joe. Thanks to everyone who's joining us this evening. It's my real pleasure to present the third lecture in this series, which has been put together by a collaboration with the RCR, London School of Radiology, and also Radiology Masters, which I'm part of. And obviously, the reason why we put these webinars together is because obviously during this unprecedented time, we're unable to deliver face-to-face teaching, and so we thought this would be a great idea as radiology lends itself to webinar style teaching. So I thought I'd just go through some common radiology on-call scenarios. Currently, I'm working at Leeds Teaching Hospitals, so I'm doing a post-CCT musculoskeletal fellowship, but I've done my fair share of on-calls whilst as a trainee in Liverpool, and came across some interesting cases. So I want this to be quite interactive, and we're going to have some interactive questions, which should be quite self-explanatory. And we've got about 9 cases. We'll see how far we get, because I know that at 8 o'clock we've got an important clap for our carers time. So let's get started. So yeah, I have to plug the Radiology Masters website. If you get a chance, please do go have a look at the website. We have some bite-sized educational videos there, and we run some live screencasts as well. And I definitely urge you to go and have a look at that. So like I say, we're going to look at some emergency cases that you might encounter on call, and I've kind of focused this on non-traumatic cases and also CT, because obviously when you're on call, you're going to face all sorts of things, CT, MRI, ultrasound, but we only have about 45 minutes, so we'll do CT and we'll do non-traumatic cases, and this is really geared towards people who are going to start their on-call soon, because you know, we know that a lot of our jobs are changing at the moment, but the on-calls will always remain, and the same kind of emergency cases should be coming through. And like I say, yeah, we've got some multiple choice questions as well. Okie dokie. So case 1, so this is a video. There's actually videos for each of these cases, and what I'll do is I'll run through them 2 or 3 times so you have plenty of chance to have a look. This first case is a 60-year-old male, and he's presented to A&E with a sudden onset right arm and leg weakness. And I'm just going to play this now. Hopefully you can all see this. And like I say, it whizzes through quite fast, so I'm just going to manually go through it and give you a chance to have a look. Okay, I'll go for it one more time. Okie dokie. So if we could go to the first question. What is the diagnosis here? Is it A, subarachnoid hemorrhage, B, stroke, or C, venous sinus thrombosis? Excellent. So hopefully all of you can see the poll results, which is that 85% of you, the majority of you, said stroke, which is the correct answer. So that's great. So we're going back onto the presentation now. And stroke is a correct answer. And this is the specific slide that shows this stroke. So here you've got this hyperdense left MCA, and that's one of the earliest signs of an acute stroke, ischemic stroke on CT. So a little bit about acute infarcts. Again, this will be bread and butter for most of you, but maybe for people who are just going on call, it's good to refresh your memory a little bit. So we know that MRI is actually more sensitive for acute infarctions than CT, but in the out of hours setting, we're always going to do CT first because it's obviously much more available, it's faster. And the important thing is we can rule out acute bleeding, and obviously we know that that's a contraindication for thrombolysis. So besides the dense vessel, which we saw on this scan, what are the other signs of an early infarct on CT? So also you've got loss of the insular ribbon, also hypoattenuation of the lentiform nucleus. And I definitely recommend using stroke windows. So just alter your windows because it just makes a world of difference. And later on, 3 to 6 hours after the initial insult, you'll start seeing a wedge-shaped hypoattenuation involving both the grey and white matter. So it goes out right to the periphery, which is how we know that this is cytotoxic edema. Okie dokie. So rather than vasogenic. Okie dokie. So now, this is the same patient, but the CT was taken maybe 3 hours later, and you can start to see that this left-sided lentiform nucleus looks quite hazy compared to the right side, and also you've started to see this loss of differentiation of the grey and white matter, and soon you're going to get a wedge-shaped infarct here. Okie dokie, so we're on to case 2 now. So the first case was fairly simple, just to ease us into it. Case 2, we are looking now at a 25-year-old female, and she's presented with a few hours of headache and vomiting. So here we go, we'll look at this video again. So I'm just going to go through it again. A little bit slower this time. And just once more. Okie dokie. So let's look at the questions. So what's the diagnosis? So we've got the same options actually, A, subarachnoid hemorrhage, B, stroke, or C, venous sinus thrombosis. So let's go to the poll. Excellent. So we have the results, and actually this time, well, we still have a majority for C, which is venous sinus thrombosis, and that's actually the correct answer. Some people thought it was a subarachnoid hemorrhage, which is reasonable. So let's just have a look at this case in a bit more detail. So just on this still here, you can see this hyperdensity, which is in the posterior part of the brain. So you could be forgiven for thinking that's a bleed, but actually when you look at it a little bit closer, it looks very much in the territory of the right transverse sinus. And remember, the history I gave you was of a few hours headache and vomiting for this patient. So it's a slightly unusual history for a subarachnoid hemorrhage, which is usually a sudden onset thunderclap-like headache. So if we just look at the coronals, it helps us a little bit actually. So we did an unenhanced here, my cursor is over, and you can see again that there's some density in the right transverse sinus. And we followed this up with an enhanced scan, and actually you can see that there's a filling defect which corresponds with this. So this confirms that this is a venous sinus thrombosis. I would definitely recommend that you just familiarize yourself with the anatomy of the venous sinus thromboses before you go on call. It will just get you out of a sticky spot when you're on call. So again, just a few pointers about venous sinus thromboses. So risk factors, infection, including mastoid and middle ear infections, as well as prothrombotic states. So pregnancy, if you're on the pill, if you're dehydrated, and even trauma. So skull fractures that extend to the deep venous sinuses can predispose you to having a thrombosis there. Obviously, we've just talked about the unenhanced CT is helpful in that it will show the hyperdensity in the sinus. It may also show you these cortical peripherally based venous hemorrhages, which are not in an arterial territory. And we'll see an example of that in just a second. And just like we showed on the previous slide, the enhanced CT will show a corresponding filling defect. And on the axial slice, this is called an empty delta sign, and we'll see that again on the next slide. So just a few pointers to be aware of. They don't always have to be symmetrical, the venous sinuses, and you can get hyperplastic sinuses. So just beware of that it can be a normal variant for them not to be symmetrical. And the other thing is that arachnoid granulations in the enhanced CT can sometimes mimic filling defects. But what you need to do is just have a look on the unenhanced scan, and it should be of CSF density if it is a true arachnoid granulation. And these are just outpouchings of the arachnoid into the venous sinuses. So that's just a few tips about how to make sure you're definitely looking at a venous sinus thrombosis. So this is just taken from a book on emergency radiology, and here the axial size, you can see that there's obviously density in the superior sagittal sinus, and on the enhanced scan you can see that there's a filling defect now, and this is what's called the empty delta sign. And here you can also see this peripherally based non-arterial territory hemorrhage, and this is very typical of the venous hemorrhages that you get with venous sinus thromboses. Excellent. So we're already done 2, which is great. We'll go on to case 3. Like I say, if you've got any questions, just write them in the chat box and we'll deal with them at the end if we've got time. So we're on to case 3. Now, this is a 43-year-old male with a sudden onset right-sided, that's meant to say, right-sided neurology, and the stroke team has called you and they're saying, we think it's a stroke. Can you just tell us it's okay for thrombolysis? Okay. So, sorry, that just stalled for a second. So I'll warn you, this is a slightly more tricky CT, so I want you to really carefully have a look. I'm just going to direct you to where the pathology is, just to make it a little bit easier. Why not? Okie dokie. So hopefully you've all had a look at that, and we've got the same options for the questions. So if we go to the poll again. Like I say, this one is a little bit tricky, but it's an important case. Okay, excellent. So most of you, again, have got the correct answer, which is subarachnoid hemorrhage. Few of you thought it was a stroke, and very few thought it was a venous sinus thrombosis. So if we just have a look at, so the correct answer was subarachnoid hemorrhage. So if we just look at this particular slice, if I just draw your attention to this linear hyperdense, I know it's very subtle, but again, this is when windowing really comes in handy. So if you just look on this side, on the right side, you've got a nice sulcus here with CSF in it, but on the other side, corresponding side in the left cerebral hemisphere, there's hyperdensity there, and that definitely catches your eye. And this is in keeping with a subarachnoid hemorrhage. And the reason why this is really important, obviously, to pick up is that this obviously is a contraindication to thrombolysis. And the first thing you need to do with this case is pick up the phone, call the stroke team and tell them not to thrombolyze. So again, these are just the basics for subarachnoid hemorrhage. So we know that this is bleeding into the subarachnoid space. As I said, it presents typically with a thunderclap headache, but not always. So you have to kind of bear that in mind. For instance, this particular patient presented like a stroke. And there's, you can get traumatic subarachnoid hemorrhages, but the more common is the non-traumatic subarachnoid hemorrhages, and this is usually due to an underlying intracranial aneurysm. So the next steps that you do would be to look for a CTA, to look for an underlying aneurysm for this patient, because he's not had any trauma, so he's quite likely to have an intracranial aneurysm. And if that is found, then later on that can be coiled so that he doesn't get further subarachnoid hemorrhages. Okay, so we're on to case 4 already. And this time, this is a 32-year-old male with a sudden onset headache. And so just have a look at this. So let me just go through it manually. Okay, so let's have a look. The same options again. So if we go to the poll, okay, so the answers again correct. So majority of you were correct with option A, which was subarachnoid hemorrhage. This is quite a special type of subarachnoid hemorrhage, so I wonder if anyone picked that up. So on these particular slices, you can see the hyperdensity, which is around the basal cisterns here and here. And I wonder if anyone was able to pick up that this wasn't a straightforward arterial aneurysmal subarachnoid hemorrhage. This is actually in keeping with a perimesencephalic subarachnoid hemorrhage, and this only accounts for 5% of subarachnoid hemorrhages, so they are quite rare. And how do you tell that this is a perimesencephalic subarachnoid hemorrhage? Firstly, the location. So compared to the arterial ones, it's usually around the basal cisterns, whereas with the aneurysmal ones, it's usually around the circle of Willis, so a bit more superior. Like I say, obviously the aneurysmal ones are cause an arterial bleed, whereas these perimesencymal subarachnoid hemorrhages cause venous hemorrhages, and they actually have a much better prognosis, and it's usually just a conservative management for that. Excellent. So we've done a whiz through of the first 4 cases, and what we need to look at now is case 5. So we've already looked at the head, and now we're moving on to the chest. Okay, so we'll go through that again. A little bit slower this time. This one's quite straightforward. 43-year-old female with chest pain and shortness of breath. So what's the diagnosis? Is it A, pulmonary embolism, B, aortic dissection, or C, aortic aneurysm? If we could go to the polls. Excellent. So yeah, like I said, this was really quite straightforward. It's a pulmonary embolism. It's not an aortic dissection. If we go back to this is the money shot really. So you can see obviously that there is this filling defect, which is almost really like a saddle embolus going across both main pulmonary arteries. And this is a very common scan that you're going to come across on call. CTPAs get done all the time out of hours. The first thing, just a few pointers for anyone looking at CTPA maybe for the first time. Obviously, you've got to make sure that it's a good quality study. On a CT, what you're looking for is any filling defects anywhere in the pulmonary arterial tree. And I definitely look at it in all 3 planes and just scrutinize every branch of the pulmonary arterial tree. The other things you want to look out for are things like right heart strain. And how does that look? Well, it's straightening or bowing of the intraventricular septum, and reflux of contrast into the IVC can also tell you that there's a degree of right heart strain. Also, as a complication of a PE, you can get pulmonary infarcts, so it's always worth looking for them. So what would that look like? They look like wedge-shaped peripheral lung parenchymal changes, and they can cavitate later on. So this is an example of a lung infarction, and there's a little bit of cavitation within it, and it's usually kind of along the pleura like this. Okay, so we're doing really well here. We're on to case 6 already. This was actually another CTPA done in a patient presenting with chest pain. And we're just going to have a look at these scans. Obviously, they're done in different phases. Okay, so we're just going to have a look back through that. So clearly here we've done a CTPA, and this has been followed up by an arterial phase scan, aortic phase scan. So what is the diagnosis here? Is it a pulmonary embolism? Is it aortic dissection? Or is it aortic rupture? So if we go to the polls. Excellent. Okay, that was really easy, obviously. So how do we know it was a dissection though on the initial scan? So if we just go back to this initial scan, which was the CTPA here, the sign here, which is why we ended up doing an aortic phase scan, is this calcification, the intimal calcification, which has medialized into the middle of the aortic arch, and that means that there's a layer of blood in between the intima and the media there. So, i.e., this is a dissection, and it's very, very clear once you give the contrast into the aorta that there's a dissection flap there. This is actually another example of the same thing, so a CTPA on which an aortic dissection was found. And again, you can see this sort of rim of hypodensity around both the ascending and descending aortas, thoracic aortas, and this was found to be another dissection. And the moral of the story really here is chest pain can be due to lots of different things, not just PEs. And so always look for other causes of chest pain on a CTPA. The medialization, like we showed in that particular CT, is a really important sign. And don't hesitate to do an arterial phase scan if you're concerned. The classification that's often used is the Stanford, sorry about the typo there, Stanford dissection. So type A is when the ascending aorta is involved, which usually has a surgical management, and type B is when the descending aorta is involved, which usually has a more conservative management. Perfect. Okay, so like I say, we're just whizzing through these and just giving small pearls of wisdom as we go along. So we're on to case 7, so we're into the abdomen now. And this is a 72-year-old male who is presenting with acute abdominal pain and low blood pressure. So let's have a look through the scan. Okay, we'll have another look. Okie dokie. So what is the diagnosis here? The options are A, aortoenteric fistula, B, aortic dissection, or C, aortocaval fistula. So if we go to the polls. Excellent. So this one has a little bit more of a divided, it's divided the audience a little bit. So the majority is still right. So it's an aortocaval fistula. Some people think it's a dissection, and few people think it's an aortoenteric fistula. So if we just go back to this this particular side, kind of is the money shot, and you can see obviously that the abdominal aorta is aneurysmal, and it contains this contrast, which if you look here, this structure next to it is the IVC, and the contrast is actually pouring into the IVC, and lower down on the scan you can see that the iliac veins are also opacified with contrast. So there's definitely a connection between the arterial and the venous system. That would explain his acute abdominal pain and also the low blood pressure because of the shunting of the blood. So this is quite an unusual and it has unusual presentation, unusual finding, and it has quite a poor prognosis, this fistulous connection between the aorta and the IVC. And obviously, the first thing you need to do is just call up the referring team and get vascular to see this patient because they need to be seen urgently. Excellent. So just going back to that case, if we talk about aortoenteric fistulas, again, they're very rare, and the things that you might see is obviously if you see a direct connection between the bowel and the aorta, if you see contrast moving from the aorta into the bowel, and also if you see locules of gas in the aorta, then that should make you suspicious as well, especially if they've had aortic intervention before. So that's just another tip about aortoenteric fistulas. Okie dokie, so case 8. This is a 69-year-old male with acute abdominal pain. He's had a background of AF, and he's had a recent attempt for a PEG insertion. So let's just have a look at this. Okay, we'll go for it again. And just for those of you that didn't quite see the abnormality, I'll just go a little bit slower. Okie dokie. So the options here are A, ischemic bowel, B, appendicitis, or C, diverticulitis. So if we go to the poll, okay, the answers, yep, again, the majority is correct. We've got some clever registrars here today. This is ischemic bowel. And why is it ischemic bowel? So now the other question is, which vascular territory is affected? So you can tell that as well from the CT. Is it the celiac axis, SMA, or IMA? So if we go back to the poll, okay, so this has a bit of a mixed reaction from people. So we've got 13% who say celiac axis, 51% who say SMA, and 36% who say IMA. And actually, this is the first one that we've not had majority with the right answer. This is actually IMA, and I'll explain why. So if we go just back to this scan, just here. So as we scroll through, this is an arterial phase scan. As we scroll through, we can see that there is long segment concentric thickening, which starts sort of 2/3 of the way along the, starts about here where my cursor is, 2/3 of the way along the transverse colon. It goes right down into the descending colon. It's still concentrically thickened. There's some pericolic fat stranding. It looks very edematous, that bowel, and just going down, it just continues all the way into the sigmoid. Okay, and that is the IMA territory. So the from 2/3 of the way of through the transverse colon down to the sigmoid, that is the IMA. So the correct answer here is IMA. The next thing you do, obviously, this is an arterial phase scan, is to look at the IMA to see if there's any blockage there. And this is the IMA coming off the aorta. But actually, in the perfect case, you would see a blockage, but you can't see one here, but there obviously must be an IMA blockage. And the reason why this history here is quite important is because he's had a background of AF, so that means he must be on anticoagulation, but because he's had a recent attempt for a PEG insertion, they would have stopped that anticoagulation, and that all kind of makes sense as to why he would be prothrombotic and why he's developed bowel ischemia. I think someone put diverticulitis. I don't think you can convincingly see any diverticulae in that thickened bowel. But obviously that is a very common cause of left-sided bowel pathology. So like I said, yep, so what will you see in ischemic bowel? You'll see long segment concentric thickening. You'll see dilatation of the bowel as well, which is an important thing to remember because it's not just obstruction that can cause dilatation of the bowel. Pneumatosis and portal venous gas are fairly late signs of ischemia, and portal venous gas specifically is quite a terminal sign of ischemia. And then you can get hyper or hypoattenuation of the bowel wall just because of the altered vascularity severity of it. Like I say, think about the history. So if you thought kind of laterally outside of the box with this particular patient, and the reason why I put this scenario in is because this is precisely the history that I had for one of my long case questions in the 2B exam. So they kind of wanted you to sort of put two and two together to say that, you know, this patient must be on anticoagulation, but it's been recently stopped and therefore they're prothrombotic. And definitely for the extra points, you need to think about which vascular territory is affected. And I think this particular case really beautifully shows the vascular territory of the IMA. Excellent. Okay, so we're actually on to the last case already, which is great. We've done this really fast, which is great, and we'll be done well in time for 8 o'clock. So the last case here is a 29-year-old female, and she's presenting to A&E with acute abdominal pain. Sorry, it's carrying on now. So if we look at that again, go a little bit slower. Okie doke. So what is the diagnosis here? Is it A, hemoperitoneum, B, appendicitis, or C, bowel obstruction? So if we go to the poll, please. Excellent. Okay, so the majority have got it right. It's A, hemoperitoneum. So if we go back to the slide, let's may as well answer the second part of question 9, which is which of these is a differential in this particular patient? And you're allowed more than one answer. Okay, so I mean, this is a bit of a trick question, really, because all of these could lead to hemoperitoneum in a young woman. So actually, all of them are correct. The thing with CT in pelvic pathology, in acute gynae pathologies, is that it doesn't really go so far. All you can tell on that initial CT, if we just go back to it, is that there's definitely fluid in the abdomen. And what's really important is to just check the Hounsfield units. As we just go down the CT, you can see there's loads of fluid in the abdomen, and particularly in the pelvis here, this fluid is starting to look really quite dense, and the uterus here is in the middle of it, and you can't really tell much about the uterus. Here you can't really see the ovaries very well, but the fact that the blood is kind of centered in the pelvis, it's a young woman presenting with acute abdominal pain, you have to think about gynecological emergencies. Of which these 3 ectopic pregnancies or ruptured hemorrhagic ovarian cyst or even a ruptured endometrioma could be the underlying cause. With this particular patient, this turned out to be a ruptured hemorrhagic ovarian cyst, and if the patient is well enough, and you know, if it's the right clinical setting, you could go on to do ultrasound or even MRI. But clearly, the patient was quite unwell. I think this particular patient just went straight to theatre. Great. Okay, well, that's actually the end. If there's any we do have a few minutes for questions, if there are any. So yeah, if you want to ask any questions, go ahead. So regarding dural sinus thromboses, do the thrombus enhance? Not to my knowledge. When you give the contrast in a CT, it should actually be a filling defect, like I showed with that particular case. So rather than enhancing, it should just be a filling defect. Okay. Is that a second question? best CT settings to detect subtle subdurals? So the hemorrhage windows, I used to use 180/80 when I did my on calls. But everyone has their own preference because it's your eyes after all. But I definitely would have, windows for looking for infarcts and windows for looking for hemorrhage. And Dr. Curtis has just answered someone's question as well. How do you tell the difference between unilateral hyperplastic versus venous sinus thrombosis? So the thrombosis will be dense on the unenhanced scan, and there'll be a filling defect on the enhanced scan. The hyperplastic sinus, you won't get that density. They will just look asymmetrical. What is your recommended reading for the ST1s to prepare for on-call? So actually, my reference, which I'm just going to show you, is a great read, which is written by Dr. Curtis and Dr. Krishnam. It's an emergency radiology book. That's a great read. And then obviously I have to plug our website as well, which is Radiology Masters, and we have some great videos on there that you can just brush up your knowledge on. And generally, I think definitely what I did as an ST1 was look at all the on-call scans, in the preceding months to when I started on call. And I would just come in the morning and just see what was scanned overnight and kind of just test myself to see if I would have reported it correctly. And that's just a great way of you preparing yourself for the on-calls. Okay, John, thankfully Dr. Curtis is fielding some questions. Ultrasound appearances of malrotation peds. Yeah, I mean, I'm lucky in that I didn't have to ever cover peds on call, but I know the findings. So on ultrasound, the thing that you'll see is the inversion of the relationship of the SMA and the SMV. So they will be on the wrong side to each other, and that tells you that there's a malrotation. And obviously in the pediatric population, that is one of the few emergencies that you definitely want to be calling your consultant about for advice. And they may go on to have a water-soluble study, which will show that the duodenum doesn't cross the midline. And obviously the complication that everyone worries about is ischemia. So you want to definitely, that's one of the things that you'd get up in the middle of the night to do. Okay. So another question here is regarding the subarachnoid arterial example, would you suggest going on to CTA? The hemorrhage was small, far away from the circle of Willis. Yeah, I agree with you, but I'd still do a CTA because there was no trauma in the history, and there still might be an aneurysm which has caused that bleed. But I agree with you, it's not that typical circle of Willis subarachnoid hemorrhage. Okay, I think that's all the questions. There's quite a few questions actually, which is great. So, and thanks a lot.